Welcome to the deep dive. Today we're doing just that, plunging into the human body's hidden orchestra, the endocrine system.
Right.
It's often seen as this mysterious network. Maybe it's something people only connect with, say diabetes or maybe thyroid issues. But really, it's a powerhouse. These hormones influence pretty much everything your energy day to day, even how strong your bones are.
And it's way more impactful than many people realize. And what's genuinely surprising, I think, is that this system, it's often kind of overlooked, but it's actually the third most common system doctors deal with in endocrinology.
Wow, third most common.
Yeah. And to really get how important it is, think about this. Some disorders linked to it, like ones leading to certain hip fractures, they can have a really sobering 25 to 50% mortality rate within just 6 months.
That's staggering. So it's not just about the fracture itself.
Exactly. It speaks to how fundamental this system is for our overall health, our resilience. So this deep dive, it's our mission, really, to cut through the complexity, pull out the key nuggets of knowledge from the sources we've looked at.
Kind of a shortcut for everyone listening.
Exactly. A shortcut to being well-informed about these critical internal systems. And hopefully we'll uncover some surprising facts and, practical insights along the way.
Okay, sounds great. So let's unpack this. Maybe start with two of the big ones, the most commonly talked about endocrine challenges: diabetes and thyroid issues.
Good place to start.
We'll begin with diabetes. Our sources really stress it's more than just sugar.
Definitely.
One source even said the whole planet is diabetic, which is obviously hyperbole, but it highlights the scale. And it's not some sweet disease. It's something that can unfortunately lead to really serious complications, fatal ones, even if it's not managed well.
That's absolutely right. And when we talk diabetes, there are different types. Type 1, for instance, is about 90% autoimmune.
Meaning the body attacks itself.
Precisely. The immune system goes after the insulin-producing cells in the pancreas. And it's often linked, you find, with other autoimmune conditions like certain thyroid problems or celiac disease.
Interesting.
And there's this fascinating thing with type 1 called the honeymoon phase.
Okay.
It's this period, sometimes after diagnosis, where the pancreas still manages to squeak out a little bit of insulin, like a temporary reprieve.
Ah, okay.
And it's really important. Doctors recommend continuing insulin therapy then, even if it's a tiny dose. The idea is to protect those remaining cells, maybe stretch out that natural function as long as possible.
That makes sense. Preserve whatever you can. And speaking of surprises, you mentioned type 1. Our sources point out something pretty striking. Nearly 10% of adults diagnosed with type 2 diabetes actually have type 1.
Yeah, that's LADA, latent autoimmune diabetes of adulthood.
Okay, so it looks like type 2 at first.
Kind of. But it's actually autoimmune, like type 1, just slower onset usually.
Yeah.
And this isn't just like a statistic. It's crucial because it means some people might be on treatments that aren't quite right for them long term.
So how would doctors, or even the patient, start to suspect it might be LADA and not typical type 2?
Good question. There are clues. They look for someone diagnosed as an adult, maybe say between 35 and 50. It often comes on more acutely than type 2.
Right, quicker symptoms.
Exactly.
Yeah.
And often the person has a leaner body type, maybe a BMI under 25, plus a big one, a personal or family history of other autoimmune diseases. If you have 2 or more of those, it's a strong signal to, dig deeper.
Got it. And type 2 diabetes, that's different.
Yeah, type 2 is more about 2 things happening. One is insulin resistance. The body just doesn't respond well to the insulin it makes. And the second is that over time, the pancreas gradually loses its ability to pump out enough insulin. Beta cell failure, we call it.
So for many type 2 patients, their treatment needs might change over time. They might need more help.
That's right. It's often progressive, meaning many will eventually need additional therapies, maybe even insulin down the road, to keep their blood sugar controlled.
Okay. So let's talk about insulin management. The sources mention different types: basal, prandial, regular, correctional.
Right. Basal is your background, long-acting insulin. Keeps things steady between meals and overnight. Prandial is mealtime insulin. You take it just before or with your food, ideally 5-15 minutes before.
Okay.
Regular insulin needs a bit more lead time, maybe 30 minutes before eating. And correctional insulin is like a touch-up dose, used when your sugar is unexpectedly high.
And what about those confusing overnight patterns, the dawn phenomenon and Samoji effect?
Yes, the dawn phenomenon is pretty common. It's a natural rise in blood sugar in the early morning, like 3 or 4 a.m. onwards. It happens because your body releases hormones, like cortisol, kind of getting you ready for the day.
Okay, a natural wake-up signal.
Sort of. The Samoji effect is different. That's a rebound high blood sugar that happens after your sugar went too low overnight. the body overcorrects.
So low then high.
Exactly. And figuring out which can be tricky. That's where things like continuous glucose monitors, CGMs, are incredibly helpful. They show you the pattern.
Makes sense.
And generally for mealtime insulin, the goal is to have it working right when the food hits your system. So taking it just before or as you start eating is usually best, mimicking that natural insulin release.
Beyond insulin, what about other key medications? Metformin comes up a lot.
Metformin is, usually the first go-to for type 2. It's effective, generally safe, and it actually has known cardiovascular benefits, which is huge. Protects the heart.
But not for everyone.
Not for everyone, particularly if someone has significant kidney problems like a creatinine clearance below 35, it's usually contraindicated.
Okay. And the newer drugs, GLP-1s and SGLTs.
Right. The newer classes are really changing things. GLP-1 agonists, you might hear names like liraglutide, semaglutide, exenatide. They help with blood sugar and often lead to weight loss, which is a major plus for many type 2 patients.
Weight loss is a big one.
Huge. And then the SGLT2 inhibitors, like empagliflozin, canagliflozin, dapagliflozin, these are really exciting because they show impressive benefits not just for blood sugar, but also for protecting the heart and the kidneys.
Wow. Multiple benefits. Any downsides?
They have potential side effects, yeah. Things like genital yeast infections because you're excreting more sugar in the urine, and increased urination generally, osmotic diuresis.
Good to know. And any older drugs to be cautious with?
Well, some older sulfonylureas, like glyburide, have a very long half-life. They stick around a long time. Meaning they carry a higher risk of causing prolonged low blood sugar hypoglycemia. So they're generally not recommended for older patients. They're on the beers list for that reason, especially if someone is dehydrated or has kidney issues.
Okay, important caution. Now, thinking about complications. Diabetic peripheral neuropathy. Nerve damage, right? Often in the feet.
Yes, exactly. It can cause pain, tingling, numbness, burning. Really uncomfortable. Treatments often involve medications originally developed for depression or seizures, like duloxetine or pregabalin, because they work on nerve pain pathways. Topical creams like capsaicin can help too.
Any specific advice for using those, say, in older folks?
Yeah, with drugs like pregabalin, it's really important to start with a low dose in elderly patients. They can be more sensitive to side effects like dizziness or confusion. Start low, go slow.
Makes sense. And protecting the kidneys. You mentioned the SGLT2s help.
They do, but blood pressure control is also absolutely paramount. Keeping blood pressure ideally less than 120/80 is crucial. Often using ACE inhibitors, ARBs, or calcium channel blockers that really helps prevent or slow down diabetic nephropathy, kidney disease.
What about triglycerides? I know high levels are bad, but can they cause other problems besides heart disease?
Oh, definitely. Very high triglycerides, especially over, say, 500 milli-GDL, significantly increase the risk of pancreatitis. That's inflammation of the pancreas. That can be really serious.
500 is the threshold.
Risk starts going up, then yeah. If levels get really high, like 2,000 or more, the risk is substantial. If someone has levels over 500 and their blood sugar is also sky high, sometimes an insulin infusion is used to bring both down quickly.
And if the sugar isn't that high?
In severe pancreatitis, or if the glucose isn't extremely elevated with the high triglycerides, a procedure called therapeutic plasma exchange, or apheresis, might be needed. It physically removes the triglycerides from the blood. Statins, the cholesterol drugs, can also help lower triglycerides a bit, maybe 10–30%.
Okay. Switching to the other extreme, hypoglycemia, low blood sugar.
Right. Also very serious. We define significant hypoglycemia as a level below 54 milli-GDL. An alert value is anything below 70 milli-GDL.
Right.
That's the point where you need to take action, eat some fast-acting carbs.
And sometimes people stop feeling the warning signs.
Exactly. That's called hypoglycemic unawareness. They don't get the usual shakiness, sweating, pounding heart, which is incredibly dangerous because they might not realize they're low until it's really severe.
How do you treat that unawareness?
It involves careful adjustment. You actually reduce their insulin doses temporarily, letting their blood sugar run a bit higher than usual for several weeks. It sounds counterintuitive, but it can help reset the body's ability to sense and respond to lows again.
Fascinating. And quickly, DKA, diabetic ketoacidosis.
DKA and HHS, hyperosmolar hyperglycemic state, are emergencies. DKA often has nausea, vomiting, abdominal pain. The critical point doctors watch for is potassium. If the patient's potassium level is low, below 3.3, you absolutely must delay giving insulin.
Why is that?
Because insulin itself drives potassium into cells, lowering the blood level further. If it's already low, giving insulin could trigger dangerous heart rhythm problems.
Yeah.
So fix the potassium first, then give insulin.
Got it. Okay, let's shift gears. The thyroid. Our sources joke everyone has fatigue thyroid problem.
Huh, it feels that way sometimes. Fatigue is such a common symptom, and thyroid issues are very common.
So let's start with hyperthyroidism, too much thyroid hormone.
Too much energy.
Right.
Exactly. Classic symptoms are feeling hot all the time, losing weight without trying, maybe a racing heart, anxiety, tremors. Sometimes doctors can hear a bruit, like a whooshing sound, over the thyroid gland because of increased blood flow.
How's it diagnosed?
Starts with blood tests. TSH, thyroid-stimulating hormone, and free T4, the main thyroid hormone. TSH will typically be very low, suppressed, and FT4 will be high.
And then figuring out the cause.
That's where the radioactive iodine uptake scan, the RAIU, comes in. It tells you why the thyroid is overactive. If the gland takes up a lot of radioactive iodine, high uptake, it means it's actively overproducing hormone. That points towards Graves' disease, which is autoimmune, or maybe a hot nodule or multiple nodules working overtime.
And low uptake.
Low uptake means the thyroid isn't actively making too much hormone. Rather, preformed hormone is leaking out. This happens in thyroiditis, inflammation of the gland, or if someone is taking too much thyroid hormone medication.
Okay, so thyroiditis itself has different types.
It does. There's subacute granulomatous thyroiditis, which is usually quite painful in the neck, often after a virus. It's treated with anti-inflammatories, maybe steroids. Then there's painless thyroiditis, sometimes called silent thyroiditis, often linked to anti-TPO antibodies. Symptoms are usually milder, it tends to resolve on its own, maybe need beta blockers for heart symptoms. And postpartum thyroiditis, which happens obviously after pregnancy, usually within 1 to 6 months.
Complicated. What about medication-induced thyroid issues? Amiodarone.
Amiodarone. That's a heart rhythm drug, notorious for thyroid effects. It contains a lot of iodine. It can cause both hypothyroidism and hyperthyroidism, or thyrotoxicosis. There are two main types of amiodarone-induced thyrotoxicosis. Type 1 is increased hormone production, treated with antithyroid drugs. Type 2 is destructive thyroiditis, treated with steroids. Often the amiodarone can actually be continued if needed for the heart, managing the thyroid issue alongside it.
And thyroid storm. That sounds serious.
It is extremely serious. A life-threatening emergency. Mortality can be 15–20%. It's usually triggered by something, a bad infection, surgery, sometimes even IV contrast with iodine in someone with underlying hyperthyroidism.
What are the symptoms?
Extreme symptoms. Very high fever, really fast heart rate, maybe heart failure, confusion, agitation, even coma. It requires immediate intensive treatment in the hospital with a combination of drugs. Beta blockers, antithyroid drugs like PTU, iodine solution after the PTU, and high-dose steroids.
Wow. Okay. And for Graves' disease, the autoimmune kind, sometimes there are eye problems.
Yes, Graves' ophthalmopathy, bulging eyes, double vision, irritation. For treating the Graves' disease itself, methimazole is usually the preferred antithyroid drug. But there's a caveat for pregnancy.
Right, you mentioned that.
Yes, in the first trimester of pregnancy, PTU is generally recommended instead of methimazole, because methimazole has a small risk of causing birth defects early on. After the first trimester, they often switch back to methimazole.
Okay, switching to the other side. Hypothyroidism. Underactive thyroid. Low energy.
Pretty much the opposite picture. Fatigue, constipation, feeling cold, dry skin, maybe hair loss, sometimes slower reflexes on exam.
How's that diagnosed?
Usually straightforward for primary hypothyroidism. TSH level will be high, and the free T4 level will be low. Hashimoto's thyroiditis, another autoimmune condition, is the most common cause in places with enough iodine.
But sometimes the problem isn't the thyroid gland itself.
Right. That's central hypothyroidism. The issue is higher up, in the pituitary gland or the hypothalamus in the brain. They aren't sending the TSH signal properly. So in central hypothyroidism, both TSH and free P4 are low, or TSH might be inappropriately normal despite a low T4.
There's a crucial step before treatment here.
Absolutely critical. Before starting levothyroxine, the thyroid hormone replacement, in someone with suspected central hypothyroidism, you must rule out adrenal insufficiency. Because cortisol, the main adrenal hormone, is essential for life. If someone has adrenal insufficiency and you give them thyroid hormone, it can speed up cortisol metabolism, potentially tipping them into a life-threatening adrenal crisis. So you do a test, usually an ACTH stimulation test, or check morning cortisol before starting levothyroxine.
That's vital. And how do you dose levothyroxine in central hypothyroidism? You can't follow the TSH.
Exactly. The TSH is unreliable. You adjust the levothyroxine dose based on the free T4 level, aiming to get it into the upper part of the normal range.
Okay. And severe hypothyroidism, is there an equivalent to thyroid storm?
Yes, myxedema coma, also a life-threatening emergency, thankfully rare, but mortality is high, 30–40%.
What does that look like?
Profound hypothyroidism symptoms, very low body temperature hypothermia, super slow heart rate, bradycardia, altered mental status, confusion, even coma, and this characteristic non-pitting edema or swelling. Immediate aggressive treatment is needed. Intravenous levothyroxine and usually another thyroid hormone called liothyronine, P3, plus stress dose steroids because associated adrenal insufficiency is common. And you start treatment based on clinical suspicion without waiting for all the lab results to come back. Time is critical.
Right. What about hypothyroidism in pregnancy?
Also really important to manage well. As soon as pregnancy is confirmed, women already on levothyroxine typically need to increase their dose by about 30%.
30% right away.
Yep, and then TSH needs to be monitored closely, usually every 4 weeks during the first half of pregnancy, aiming to keep it in the lower part of the normal range, specific for pregnancy. Undertreated hypothyroidism poses risks for both mom, like preeclampsia, and the baby's brain development.
Any drug interactions to be aware of?
A common one is oral estrogen, like in birth control pills, or standard hormone replacement therapy. Estrogen increases levels of thyroxine-binding globulin, TBG, the protein that carries thyroid hormone in the blood. This can effectively lower the amount of free active hormone, so women starting estrogen often need an increase in their levothyroxine dose.
Good to know. And subclinical hypothyroidism, TSH is high, but T4 is normal.
Exactly. It's like a borderline state. Whether to treat it is a bit debated and depends on the situation.
What are the general guidelines?
Generally, treatment is considered if the TSH is consistently 10 OUML or higher. If it's mildly elevated, say between 7 and 9.9, treatment might be considered if the patient is younger than 70, has symptoms suggestive of hypothyroidism, has an enlarged thyroid, goiter, or has positive anti-TPO antibodies, suggesting Hashimoto's.
And for older patients?
For older adults, especially over 70 or 75, TSH levels naturally tend to creep up a bit. The TSH as high as 8.0 might actually be physiologically normal for them, and treating it might not provide benefit, potentially causing harm if overtreated. So the threshold for treatment is often higher in the elderly.
Okay. Last thyroid topic, nodules. Those lumps in the neck, are they usually cancer?
Thankfully, no. Most thyroid nodules, the vast majority, are benign. Only about 4 to 6% turn out to be malignant or cancerous.
So how do you evaluate them?
First steps are usually checking the TSH level and getting a thyroid ultrasound. The ultrasound gives detailed information about the nodule size and characteristics.
What makes a nodule seem more suspicious for cancer?
Several things raise red flags. Age, either very young, under 30, or older, over 60, if the nodule is growing quickly. If it feels very hard or seems fixed to surrounding tissues, if there are swollen lymph nodes nearby, obstructive symptoms like new hoarseness or trouble swallowing. Also, a TSH level that's high or even high normal can be associated with increased risk, and then specific features on the ultrasound. Things like microcalcifications, tiny calcium specks, being very dark or hypoechoic, having irregular margins, being taller than wide, or having increased blood flow within the nodule itself.
So how does the TSH level guide the next steps?
If the TSH is low, suggesting the nodule might be overactive, the next step is usually that radioactive iodine scan, scintigraphy. Hot nodules that take up iodine are almost never cancer and are managed for hyperthyroidism. Cold nodules that don't take up iodine are more suspicious and usually need a biopsy, a fine needle aspiration, or FNA.
And if TSH is normal or high?
If the TSH is normal or high and the nodule has suspicious features on ultrasound or the patient has risk factors, then you typically proceed directly to the FNA biopsy without the iodine scan.
And if it is thyroid cancer?
Treatment usually involves surgery to remove the thyroid, often followed by radioactive iodine therapy to destroy any remaining thyroid tissue, and then lifelong levothyroxine. The levothyroxine serves two purposes: replacing the hormone the thyroid used to make and suppressing TSH production from the pituitary gland.
Why suppress TSH?
Because TSH can potentially stimulate the growth of any residual thyroid cancer cells. For higher-risk cancers, like certain types of papillary thyroid cancer, the goal is often very aggressive TSH suppression, aiming for levels less than 0.1. This can improve survival, but it does come with risks of its own, like potential heart rhythm issues, atrial fibrillation, and bone loss over time.
A balance, then. And medullary thyroid carcinoma, you mentioned that's different.
Yes, MTC is less common and arises from different cells in the thyroid. It's often linked to genetic syndromes, specifically multiple endocrine neoplasia type 2. MEN2, caused by mutations in the RET gene. So if MTC is diagnosed, genetic testing for RET mutations is crucial, not just for the patient, but also for their first-degree relatives, as it can be inherited.
Fascinating how genetics plays into it. Okay, let's move up the command chain, so to speak, to the pituitary gland, the body's CEO, and its neighbors, the adrenal glands.
But the master regulators.
Starting with the pituitary not working enough, hypopituitarism.
Yes, meaning impaired secretion of one or more pituitary hormones. There are various causes. Sheehan syndrome is a rare one. It's pituitary damage caused by severe blood loss or shock during childbirth.
Okay.
And then there's pituitary apoplexy. That's an emergency. It's sudden bleeding or infarction, like a stroke, within the pituitary gland.
What are the symptoms?
Acute, severe headache, vision loss or double vision, sometimes altered consciousness. It requires immediate treatment with high-dose stress steroids because the adrenals often stop getting their signal, and urgent neurosurgery to decompress the pituitary gland. Over 2/3 of these patients develop acute secondary adrenal insufficiency. Very serious.
And those incidentalomas again, finding a pituitary mass by accident.
Yep, happens here too. Surprisingly common, maybe up to 10% of routine brain MRIs might show a small pituitary abnormality.
How are they managed?
It depends on the size. If it's small, a microadenoma, less than 10 millimeters, the main thing is to check if it's overproducing any hormones. Usually just prolactin if there are no symptoms, otherwise targeted testing based on symptoms.
And if it's bigger, a macroadenoma.
If it's 10 millimeters or larger, you need a more thorough workup. Check for both hormone overproduction and underproduction, hypopituitarism, and definitely get visual field testing to see if it's pressing on the optic nerves. If it's causing problems, hormone excess, except prolactinomas, vision issues, or pituitary deficiency surgery is often recommended. If it's non-functional and not causing mass effect, conservative management with follow-up MRIs is usually the way to go.
And if the pituitary damage leads to hormone deficiencies?
Lifelong hormone replacement might be necessary. Replacing thyroid hormone, levothyroxine, cortisol, hydrocortisone usually, and sometimes antidiuretic hormone, desmopressin for diabetes insipidus, is critical, as deficiencies of these can be life-threatening. And remember, cortisol replacement is unique. It's adjusted based on how the patient feels, their symptoms of fatigue, nausea, etc., not by aiming for a specific lab number.
Okay. What about overproduction? Hyperprolactinemia, too much prolactin.
Right. Elevated prolactin levels. It can have several causes. Some are physiologic, perfectly normal, like during pregnancy and breastfeeding, or even just from stress.
Pathologic causes.
Hypothyroidism can cause it. Chronic kidney disease. Certain medications are common culprits, especially antipsychotics like risperidone. And of course, pituitary tumors that actually secrete prolactinomas.
Prolactinomas. They're common.
They are the most common type of pituitary adenoma.
And the treatment is magic.
Well, it feels like it sometimes. The treatment for prolactinomas is usually medication, specifically dopamine agonists like cabergoline or bromocriptine. These drugs are remarkably effective.
How effective?
They normalize prolactin levels, restore normal reproductive function like periods or testosterone levels, and they actually shrink the tumor in the vast majority of cases, like at least 50% shrinkage in maybe 90% of patients. Even if there are vision problems from a large tumor, these drugs can often resolve them.
So surgery isn't usually needed.
Rarely needed for prolactinomas, which is amazing. The medications work so well. A very high prolactin level, say over 200 ng/ml, usually strongly suggests a prolactinoma is present.
What about pregnancy with a prolactinoma?
If it's a large tumor, a macroadenoma, visual field testing is often recommended each trimester because the tumor can sometimes enlarge due to hormonal changes of pregnancy. Prolactin levels themselves normally rise significantly during pregnancy, so they aren't useful for monitoring tumor activity then. The medication, like bromocriptine, is often stopped once pregnancy is confirmed, if possible, especially with smaller tumors.
Okay, moving from prolactin to growth hormone excess, acromegaly.
Right. Too much growth hormone in adulthood.
What are the telltale signs?
Characteristic physical changes. Enlargement of hands and feet. People might notice their rings or shoes don't fit anymore. Changes in facial features like a prominent jaw, prognathism, enlarged nose, forehead bossing. Also headaches, excessive sweating, high blood pressure, carpal tunnel syndrome. If it starts before puberty, before the growth plates close, it causes gigantism.
And the long-term health risks.
They are significant. Increased risk of cardiovascular disease is a major one. Cardiomyopathy, enlarged heart, hypertension. Sleep apnea is very common. And there's an increased risk of colon polyps and colon cancer.
Colon cancer.
Yes. That's why screening colonoscopy is recommended at the time of diagnosis, and then periodically, maybe every 3-4 years after age 50, depending on findings. Untreated acromegaly definitely leads to increased mortality, mostly from the cardiovascular complications and cancer.
How is it diagnosed?
First step is usually checking IGF-1 levels, insulin-like growth factor 1. It reflects average growth hormone levels and is usually markedly elevated. If IGF-1 is high, the confirmatory test is an oral glucose suppression test.
How does that work?
You drink a sugary drink, and normally that glucose load should suppress growth hormone secretion. In acromegaly, GH levels fail to suppress adequately, usually staying above 1 ng/ml. After confirming biochemically, an MRI of the brain is done to look for the pituitary tumor causing the excess GH.
Treatment. Surgery.
Surgery transsphenoidal resection of the pituitary tumor is the primary treatment and offers the best chance for cure. It's essential. However, sometimes surgery doesn't completely remove the tumor or normalize hormone levels.
Then what?
Then medical therapy is often needed. Somatostatin analogs, like octreotide or lanreotide, are injections that inhibit GH secretion. There's also pegvisomant, which is a GH receptor blocker. It stops GH from working on the body's tissues. Radiation therapy might be considered too if surgery and medications aren't fully effective, but it works slowly.
Okay, let's move down to the adrenal glands, the stress controllers. Hypercortisolism, Cushing syndrome, too much cortisol.
Right. Excess cortisol. The most common cause by far is actually taking external glucocorticoid medications like high-dose prednisone for inflammatory conditions.
Exogenous Cushing's.
Exactly. But then there's endogenous Cushing's, where the body itself is making too much. This can be from a pituitary tumor making too much ACTH, Cushing's disease, an adrenal tumor making cortisol directly, or rarely, a tumor elsewhere in the body making ACTH, ectopic ACTH.
Diagnosing it seems tricky. Cortisol levels fluctuate.
They do, so you usually need multiple screening tests to confirm excess cortisol production. The best ones are often late-night salivary cortisol measurements. Cortisol is normally lowest at night. A 24-hour urine-free cortisol collation, and the 1 milligram overnight dexamethasone suppression test.
How does the dexamethasone test work?
You take a small dose of dexamethasone, a potent steroid, at night. Normally, this should suppress your body's own cortisol production, so your morning cortisol level should be very low, usually less than 1.8 EDL. In Cushing's, the suppression often doesn't happen properly. But you have to be aware of things that can cause false positives.
Like what?
Certain medications, like oral contraceptives or some anti-seizure drugs, can interfere with the dexamethasone test. High stress levels, depression, alcoholism can also sometimes cause abnormal results. That's why multiple tests are usually needed.
And once you confirm Cushing's, how do you find the source? Pituitary, adrenal, ectopic?
The next step is measuring the ACTH level in the blood. If ACTH is suppressed or very low, it points to an adrenal tumor as the source, ACTH independent. If ACTH is normal or high, it means the problem is ACTH dependent, either the pituitary or an ectopic source.
Then imaging.
Exactly. If it's ACTH independent, you get a CT scan of the adrenal glands. If it's ACTH dependent, you usually start with an MRI of the pituitary gland. Further testing, like high-dose dexamethasone suppression tests or sampling blood from veins near the pituitary, might be needed to distinguish a pituitary source from an ectopic one.
Okay. Adrenal incidentalomas again. Found by chance on a scan, what's the key first step?
The absolute key first step with an adrenal incidentaloma is biochemical testing to rule out hormonal hyperfunction. Before you even think about size or cancer risk, you must check if it's overproducing hormones.
Which hormones?
Primarily 3. Catecholamines for pheochromocytoma, cortisol for Cushing syndrome, and aldosterone for primary hyperaldosteronism, especially if the patient has hypertension. You have to make sure it's not hormonally active first.
Why is that so critical, especially for pheo?
Because if it is a pheochromocytoma, doing a biopsy or even surgery without proper preparation could trigger a massive, potentially fatal release of adrenaline and noradrenaline, causing a hypertensive crisis. So rule out function first.
Okay, rule out function. Then when do you remove an adrenal incidentaloma?
Surgery is generally considered if the mass is hormonally functional, after appropriate prep, of course. If it's large, usually its cutoff is greater than 4 centimeters, or if it has suspicious features on the CT or MRI scan suggesting malignancy, things like irregular shape, high density before contrast, or slow contrast washout.
Let's talk about pheochromocytoma specifically, that catecholamine-producing tumor.
Right. Relatively rare, but important not to miss, often presents with classic spells or paroxysms.
Symptoms.
The classic triad is paroxysmal headaches, sweating diaphoresis, and tachycardia. fast heart rate, often accompanied by severe hypertension during the spell. But symptoms can vary.
Diagnosis.
Biochemical testing is key. Measuring plasma-free metanephrines is very sensitive, especially if clinical suspicion is high. Measuring 24-hour urine fractionated metanephrines and catecholamines is also very good. Maybe slightly more specific if suspicion is lower.
And the critical treatment precaution.
Cannot emphasize this enough. Alpha blockade first. Before any surgery to remove a pheochromocytoma, or even before procedures involving iodine contrast dye, the patient must be started on alpha-blocking medication, like phenoxybenzamine or prazosin. This controls blood pressure and prevents that dangerous hypertensive crisis during manipulation of the tumor or from the contrast. Beta blockers to control heart rate are only added after adequate alpha blockade is achieved. Never give beta blockers alone first.
Got it. Alpha blockade first. Are pheos linked to other conditions?
Yes, they can be part of inherited syndromes like multiple endocrine neoplasia type 2, MEN2, neurofibromatosis type 1, NF1, and von Hippel-Lindau, VHL syndrome. Genetic testing is often considered.
Okay, now the opposite adrenal problem, hypoadrenalism or adrenal insufficiency. Not enough cortisol.
Correct. Also a serious condition if not managed. Two main types. Primary adrenal insufficiency, also known as Addison's disease, is when the adrenal glands themselves are damaged or destroyed, most commonly by an autoimmune process.
What are the signs of primary?
Because the adrenals aren't working, the pituitary sends out tons of ACTH trying to stimulate them. This high ACTH causes hyperpigmentation, a darkening of the skin, especially in sun-exposed areas, creases, and scars. You also often see low sodium, high potassium, hyperkalemia, and salt craving, because aldosterone production is usually affected too.
And secondary adrenal insufficiency.
That's when the problem is lack of ACTH signal from the pituitary gland. So cortisol is low, but ACTH is also low or inappropriately normal. Aldosterone production is usually preserved because it's mainly controlled by a different system, renin-angiotensin. So you typically don't see the hyperpigmentation or the high potassium with secondary.
Right.
Usually starts with checking an early morning cortisol level when it should be highest. A level below 3 EDDL is highly suggestive of insufficiency. If it's indeterminate, the gold standard is the ACTH stimulation test, cosintropin test. You give synthetic ACTH and measure the cortisol response. A normal response is usually a peak cortisol level over 18 or 20 TDL, depending on the lab assay.
And the crucial management point.
Stress dosing. People with adrenal insufficiency, primary or secondary, need to increase their glucocorticoid dose, usually hydrocortisone, during times of significant physical stress, like fever, infection, surgery, major trauma. Their body can't mount its own stress response, so they need extra steroid coverage to prevent an adrenal crisis, which can cause shock and be fatal.
How much extra?
It depends on the severity of the stress. Minor illness might just need doubling the usual dose. Major surgery or critical illness requires much higher intravenous doses. Patients should wear a medical alert bracelet and have an emergency injection kit. Also, recognizing who is at risk for adrenal suppression from taking chronic external steroids is important.
Right, like those taking prednisone long-term.
Exactly. Someone taking, say, 20 milligrams or more of prednisone daily for over 3 weeks is considered high risk for having their own adrenal axis suppressed. They would likely need stress-dose steroids during the perioperative period if they have surgery. It's also good to remember hydrocortisone has both glucocorticoid, cortisol-like, and some mineralocorticoid, aldosterone-like activity, which can be helpful in primary adrenal insufficiency. Dexamethasone, for example, is purely glucocorticoid.
Okay. Last adrenal topic, primary hyperaldosteronism. Too much aldosterone.
Yes, excess production of aldosterone from the adrenal glands, independent of the renin-angiotensin system.
What does it cause?
The main consequence is hypertension, high blood pressure, which can often be resistant to standard medications. It can also cause metabolic alkalosis and low potassium levels, hypokalemia, although surprisingly most patients with primary hyperaldosteronism actually have normal potassium levels, so you can't rule it out just because potassium is normal.
Diagnosis.
Screening involves measuring plasma aldosterone concentration and plasma renin activity simultaneously. In primary hyperaldosteronism, you expect aldosterone to be elevated and renin activity to be suppressed. Low. The aldosterone to renin ratio is calculated, and a ratio typically greater than 20 is suggestive. Then, confirmatory suppression tests are usually done, like intravenous salt loading or fludrocortisone suppression.
And once confirmed, how do you find the source? One gland or both?
Imaging, usually in an adrenal CT scan, is done first, but CT isn't perfect at distinguishing between a one-sided aldosterone-producing adenoma, the benign tumor, and bilateral adrenal hyperplasia, both glands overactive. So the next step, especially if surgery is being considered, is often adrenal venous sampling, AVS.
What's that?
It's an interventional radiology procedure where they sample blood directly from the veins, draining each adrenal gland to see where the excess aldosterone is coming from. It's considered the gold standard for differentiating unilateral from bilateral disease.
Why is that distinction so important?
Because the treatment differs. If AVS confirms a unilateral adenoma, surgery, adrenalectomy, is often curative for the hyperaldosteronism and can significantly improve or even cure the hypertension. If it's bilateral adrenal hyperplasia, which is actually the more common cause, about 60% of cases, surgery isn't helpful, and the treatment is medical, using aldosterone antagonist medications like spironolactone or eplerenone. These are also used for patients with adenomas who aren't surgical candidates.
Makes sense. Okay, let's shift to our final section. The foundation's calcium, bone, and reproduction, starting with calcium and bone. The skeleton's balance.
Absolutely crucial, and calcium balance affects much more than just bones, nerves, muscles, heart.
Hypercalcemia, too much calcium, what can that cause?
Symptoms can be really variable. Sometimes people are completely asymptomatic and it's just found on routine blood work. Other times it can cause fatigue, constipation, kidney stones, bone pain. Severe hypercalcemia can lead to confusion, lethargy, even seizures or coma, and acute kidney injury. Bone stones, abdominal groans, and psychic moans is the old mnemonic.
How do you start figuring out the cause?
The very first step is always checking a PTH level parathyroid hormone. That immediately divides the causes into PTH-dependent or PTH-independent.
Okay, PTH-dependent, high PTH.
If calcium is high and PTH is also high or inappropriately normal when it should be suppressed, that usually points to primary hyperparathyroidism, overactive parathyroid glands. Urinary calcium excretion is usually high too.
But there's an important mimic here, FHH.
Yes, familial hypercalcemia. This is key to distinguish. FHH is a genetic condition that causes high calcium with high or normal PTH, but the defining feature is very low calcium excretion in the urine, usually less than 100 milligrams per 24 hours, or a urine calcium creatinine clearance ratio less than 0.01.
Why is distinguishing FHH so important?
Because FHH is generally benign and usually does not require parathyroid surgery, whereas primary hyperparathyroidism often does. Mistaking FHH for primary hyperparathyroidism could lead to unnecessary surgery.
Got it. What if the PTH is low or suppressed? PTH-independent hypercalcemia.
If PTH is suppressed, the high calcium isn't coming from the parathyroid glands. The most common cause in hospitalized patients is malignancy, cancer.
How does cancer cause high calcium?
Several ways. Some tumors secrete a substance called PTH-related protein, PTHrP, that acts like PTH. Others spread to the bones, metastases, and destroy bone, releasing calcium. Some blood cancers like multiple myeloma or lymphoma can also cause it.
Other PTH-independent causes?
High vitamin D levels. Vitamin D toxicity, usually from excessive supplementation levels, 150 ng/ml. Granulomatous diseases like sarcoidosis or tuberculosis, where the granulomas themselves can activate vitamin D. Hyperthyroidism can cause mild hypercalcemia. Milk alkali syndrome from taking too much calcium and absorbable alkali like calcium carbonate antacids. Certain medications like thiazide diuretics or lithium.
How is severe hypercalcemia treated?
Treatment depends on the level and symptoms. The cornerstones are aggressive intravenous fluids, hydration, to dilute the calcium and promote kidney excretion. Calcitonin works quickly, but its effect is short-lived. Bisphosphonates like pamidronate or zoledronate are very effective but take 24 or 48 hours to really kick in. They work by inhibiting bone resorption. They're often contraindicated in severe renal failure, though. For life-threatening hypercalcemia, for example 18 milli-GDL with neurologic symptoms, or in severe kidney failure, hemodialysis might be necessary. And obviously, treating the underlying cause is crucial long-term. For granulomatous disease, glucocorticoids are often used, not bisphosphonates if there's kidney failure.
Okay, now hypocalcemia. Too little calcium.
Also potentially dangerous, can affect nerve and muscle function.
Symptoms.
Mild hypocalcemia might cause numbness or tingling, especially around the mouth or in the fingers and toes. More severe hypocalcemia can lead to muscle cramps, spasms, tetany, seizures, and changes on the EKG, particularly a prolonged QT interval, which increases the risk of dangerous heart rhythms.
What causes it?
Several things. Magnesium deficiency is a very common and often overlooked cause, especially in people with alcoholism or malabsorption. Magnesium is needed for PTH secretion and action, so low magnesium can functionally cause hypoparathyroidism.
So check magnesium first.
Always check and replete magnesium if it's low when evaluating hypocalcemia. Other causes include true hypoparathyroidism, where the parathyroid glands aren't making enough plays. PTH often occurs after neck surgery, like thyroidectomy or parathyroidectomy if the glands are removed or damaged. Vitamin D deficiency can cause it, kidney failure, certain medications, and hungry bone syndrome.
Hungry bone syndrome.
Yeah, this can happen after successful surgery for severe hyperparathyroidism. The chronically starved bones suddenly have PTH removed and they start rapidly taking up calcium and phosphate from the blood, causing profound hypocalcemia and hypophosphatemia, usually starting 2 to 4 days post-op. PTH levels might be normal or even high initially, requires aggressive calcium and often magnesium repletion.
Management of hypocalcemia.
Replete magnesium first, if needed. Then, oral calcium and active vitamin D calcitriol supplementation for milder cases. For severe symptomatic hypocalcemia or significant EKG changes, intravenous calcium gluconate is given.
Okay, let's talk osteoporosis. Brittle bones.
Right. Defined by low bone mineral density, specifically a T-score of -2.5 or lower on a DXA scan. Severe osteoporosis is a T-score that low plus a history of 1 or more fragility fractures from minimal trauma, like a fall from standing height.
How is it diagnosed?
The standard is the DXA scan, dual energy X-ray absorptiometry. It measures bone density, usually at the lumbar spine and the hip. The lowest T-score at either of these sites is used for diagnosis. Scans of other sites, like the forearm or heel, aren't typically used for routine diagnosis or monitoring.
Who's at risk?
Risk increases with age. It's more common in women, especially postmenopausal women, and in individuals of white or Asian descent. Lifestyle factors like smoking, excessive alcohol intake, low calcium vitamin D intake, and sedentary lifestyle play a role. Family history is important, and many medical conditions and medications increase risk.
Like which ones? The secondary causes.
Yes, it's really important to evaluate for potentially reversible secondary causes. Endocrine ones include hyperthyroidism, hyperparathyroidism, Cushing syndrome, hypogonadism, low estrogen or testosterone, and untreated type 1 diabetes. Malabsorption syndromes like celiac disease, chronic kidney disease, inflammatory conditions like rheumatoid arthritis, and medications are huge culprits.
Which medication?
Chronic glucocorticoid steroid use is a major one, some anti-seizure medications, long-term use of proton pump inhibitors, PPIs for acid reflux has been linked, heparin use, certain cancer treatments, so screening labs like TSH, calcium, vitamin D, sometimes kidney function tests, and maybe a 24-hour urine calcium are often done to look for these secondary causes.
How is osteoporosis treated? Lifestyle first.
Absolutely. Lifestyle modifications are foundational. Weight-bearing and muscle strengthening exercise, smoking cessation, moderating alcohol intake, ensuring adequate calcium and vitamin D intake. Target around 1,200 milligrams of elemental calcium per day from diet plus supplements if needed, and 801,000 IU of vitamin D daily for most adults at risk.
And medications. What are the main options?
Pharmacologic therapy is recommended for those with osteoporosis, T-score and it gets 2.5, or those with osteopenia, T-score between -1.0 and -2.5, who have had a fragility fracture or have a high fracture risk based on calculators like FRIX. First-line therapy is often bisphosphonates.
Oral or IV?
Can be either. Oral bisphosphonates like alendronate, rislendronate require very specific administration, take on an empty stomach with plain water, remain upright for 30-60 minutes to minimize risk of esophagitis. They're generally avoided if creatinine clearance is less than 30-35 mmol. 4 bisphosphonates, like zoledronic acid, are given less frequently but also have kidney function limitations. A rare but serious side effect with long-term bisphosphonate use is atypical femur fractures.
Other first-line options.
Denosumab Prolia is another potent anti-resorptive agent, given as an injection every 6 months. It can be used in patients with renal insufficiency, which is an advantage, but requires careful monitoring for hypocalcemia, especially those with kidney disease. It's also important to know that starting denosumab can lead to rapid bone loss, so transitioning to another agent is usually needed if it's discontinued.
What about for very high-risk patients or those who fail first-line therapy?
For severe osteoporosis, e.g. T-score -3.0, multiple fractures, or progressive bone loss despite treatment, anabolic agents that stimulate bone formation are considered. Teriparatide, Forteo, and abaloparatide, Tymlos, are injectable recombinant human PTH analogs. They are very effective but expensive, and treatment duration is typically limited to 18-24 months. Romosozumab, Evenity, is another newer anabolic agent.
Any other options, maybe for specific situations?
Raloxifene, Evista, is a SERM, selective estrogen receptor modulator. It's approved for osteoporosis prevention and treatment in postmenopausal women. It primarily reduces the risk of vertebral fractures, not hip fractures as much. It also has the benefit of reducing invasive breast cancer risk, but it can increase the risk of hot flashes and blood clots, similar to estrogen. Nasal calcitonin is much less effective, offers only modest vertebral fracture reduction, and is generally not considered a first-line therapy anymore.
Okay, wrapping up with reproductive disorders. Amenorrhea, absence of periods. First step.
Always, always, always. Rule out pregnancy, get a pregnancy test. That's step one.
Okay, after that?
Then you figure out if it's primary amenorrhea, never started periods by age 15 or 16, or secondary amenorrhea, had periods but they stopped for more than 3 months or 6 months if irregular. The initial workup usually includes checking TSH, thyroid, prolactin, FSH, follicle-stimulating hormone, and maybe testosterone levels.
Common causes.
Lots of possibilities. Functional hypothalamic amenorrhea is common, especially in athletes or those with very low body weight or eating disorders. The brain essentially shuts down reproduction due to stress or energy deficit. FSH and estrogen levels will be low. Polycystic ovary syndrome, PCOS, is a very frequent cause of irregular or absent periods. Premature ovarian failure or insufficiency, high FSH. Structural problems like Asherman syndrome, scar tissue inside the uterus, often after D&C. Pituitary issues.
Let's talk PCOS. You said it's very common.
Extremely common. Affects maybe 7–10% of reproductive age women. One of the most common endocrine disorders in young women.
What are the criteria for diagnosing it?
You generally need 2 out of these 3 criteria, or Rotterdam criteria. 1, oligoovulation or anovulation, meaning irregular or absent ovulation, leading to irregular periods.
Yeah.
2, clinical signs like hirsutism, excess hair growth, acne, male pattern hair loss, or biochemical signs, high testosterone levels of hyperandrogenism. 3, polycystic ovarian morphology on ultrasound, meaning many small follicles.
And it's not just about periods and hair. There are other health risks.
Absolutely. PCOS is strongly linked to metabolic problems. Insulin resistance is very common, which significantly increases the risk for type 2 diabetes, gestational diabetes, dyslipidemia, abnormal cholesterol, hypertension, obstructive sleep apnea, and non-alcoholic fatty liver disease, AFLD and ASH.
Also, because of the chronic lack of ovulation and unopposed estrogen exposure to the uterine lining, there's an increased risk of endometrial hyperplasia and endometrial cancer.
So how is PCOS managed?
Management depends on the patient's goals. For example, fertility, managing symptoms. Lifestyle modification, particularly weight loss if overweight or obese, is first line and can improve many aspects: menstrual regularity, insulin sensitivity, androgen levels.
Medication. For menstrual regulation and managing hirsutismectomy, combined oral contraceptive pills, OCPs, are usually first line. The estrogen component increases sex hormone-binding globulin, SHBG, which binds up free testosterone, reducing its effects. The progestin helps regulate cycles and protects the endometrium. If hirsutism is still bothersome after 6 months or so on OCPs, anti-androgen medications like spironolactone can be added. For women trying to conceive, medications like clomiphene citrate or letrozole are used to induce ovulation. Metformin can improve insulin sensitivity and might help with cycles in some women, but it's generally less effective than OCPs for cycle regulation or hirsutism. And critically, it does not provide the same endometrial protection as progestin OCPs.
Hirsutism, that excess hair growth. PCOS is the most common cause.
By far. But if someone presents with hirsutism, especially if it's severe or came on rapidly, you do need to consider other causes. Evaluation usually starts with measuring serum total testosterone.
What else could it be?
Sometimes it's just idiopathic hirsutism. Increased sensitivity of hair follicles to normal androgen levels often runs in families. Less commonly, non-classic congenital adrenal hyperplasia, NCAH, due to 21-hydroxylase deficiency can present similarly to PCOS. Checking a 17-hydroxyprogesterone level helps screen for this. Very rarely, rapidly progressive or severe hirsutism, especially with very high testosterone levels, for example 150 or 200 NGL, could signal an androgen-secreting tumor of the ovary or adrenal gland, which needs urgent investigation. Cushing syndrome can also cause hirsutism.
Okay, flipping to male hypogonadism.
Yeah.
Low testosterone.
Right. Symptoms can be varied. Decreased libido, sex drive, erectile dysfunction, fatigue, low energy, depressed mood, decreased morning erections, sometimes loss of body hair, reduced muscle mass, increased body fat, gynecomastia, breast enlargement, and smaller shrinking tests.
How is it diagnosed?
Requires confirmation of low serum total testosterone levels, ideally measured on at least 2 separate occasions in the early morning, around 7:10 a.m., when levels are typically highest.
And differentiating the cause, primary versus secondary?
Similar to other endocrine axes, you check the pituitary gonadotropins, LH and FSH. If testosterone is low but LH and FSH are high, it indicates primary hypogonadism. The testicles themselves aren't working properly, testicular failure. Causes include Klinefelter syndrome, genetic 47,000 XXY karyotype, often small firm testes, gynecomastia, damage from lumps, orchitis, trauma, chemotherapy, radiation.
And if LH, FSH are low or normal?
If testosterone is low and LH, FSH are also low or inappropriately normal, it's just secondary hypogonadism. The problem is upstream in the pituitary or hypothalamus. Many potential causes here. Obesity is a common one, chronic illnesses, chronic opioid use, sleep apnea, pituitary tumors or damage from surgery, radiation, trauma, infiltrative diseases like hemochromatosis. If testosterone is very low, for example, 200 NGDL, maybe 150 in older men, or if there are other signs of pituitary dysfunction, pituitary imaging, MRI is often recommended.
What about fertility? Does testosterone therapy affect it?
Yes, this is a very important point. Giving external testosterone replacement therapy, TRT, suppresses the pituitary's production of LH and FSH, which are necessary for sperm production, spermatogenesis. So TRT typically leads to low sperm counts, oligospermia, or even absent sperm, azoospermia, and infertility.
So what's the alternative for men who want to preserve fertility?
For men with secondary hypogonadism who desire fertility, treatments aim to stimulate the testes directly. This often involves injections of human chorionic gonadotropin, HCG, which acts like LH, sometimes combined with FSH injections. For primary hypogonadism, fertility is often more challenging.
Any surprising causes of hypogonadism?
Anabolic steroid abuse is a significant and sometimes overlooked cause of secondary hypogonadism. While users get increased muscle mass, the external androgens suppress their natural HPA axis, hypothalamic pituitary adrenal axis, specifically the HPG gonadal axis. This leads to suppressed natural testosterone, low LH-FSH, testicular atrophy, sometimes gynecomastia from conversion to estrogen, erythrocytosis, high red blood cell count, and significant psychological changes, especially upon withdrawal.
Okay, last topic. Hormone replacement therapy, HRT for menopause.
Right. Menopausal hormone therapy, MHT, is maybe a better term now.
What's the main indication?
The primary indication is for managing moderate to severe vasomotor symptoms, hot flashes and night sweats, in recently menopausal women, typically those under age 60 or within 10 years of menopause onset. It's very effective for this. It can also help with genitourinary symptoms like vaginal dryness.
How long should it be used?
The general principle is to use the lowest effective dose for the shortest duration necessary to manage symptoms. Often recommended for less than 5 years, though duration can be individualized based on symptom persistence and risk-benefit assessment.
Estrogen only or combined?
Crucial distinction. Women who still have their uterus must take a progestogen, like progesterone or a synthetic progestin, along with estrogen. This is to protect the uterine lining, endometrium, from hyperplasia and cancer, which can be caused by adipose estrogen. Women who have had a hysterectomy can take estrogen-only therapy.
When is HRT-MHT contraindicated?
There are definite contraindications. History of breast cancer is a major one. Known or suspected estrogen-sensitive cancers. History of coronary heart disease, stroke, or thromboembolism, blood clots like DVT or PE. Undiagnosed abnormal vaginal bleeding. Active liver disease. It's also important to emphasize what is not recommended for. Based on large trials like the Women's Health Initiative, WHI, MHT is not recommended for the primary or secondary prevention of chronic conditions like heart disease, stroke, dementia, or solely for osteoporosis prevention, although it does help bone density. The risks, particularly with combined therapy started in older women, were found to outweigh benefits for these indications. The decision is really about managing bothersome menopausal symptoms in appropriate candidates.
What an incredible journey through these control systems. It really is amazing when you stop and think about the complexity, isn't it? How interconnected the whole endocrine system is.
Absolutely.
You see how just a subtle imbalance in one hormone, one little area, can just ripple through the entire body. It affects so many seemingly unrelated symptoms. It's a fascinating reminder of how everything truly is connected. So thinking about all this, what really stands out to you about how these hidden systems communicate and control so much of our health?
Yeah, it's, in a world where we're just flooded with information, I think really understanding these core hormonal functions, it almost feels like having a superpower, doesn't it? It lets you look beyond just one symptom here or there and see the bigger picture of how your body is actually working, how it's all talking to each other.
That's a great way to put it, a superpower.
So maybe the question for listeners is, how might this deep dive, thinking about all these connections, change how you interpret your own body's signals? Or maybe how you think about health issues, perhaps seemingly unrelated ones, in yourself or people you know.
Right.
Maybe it sparks a new question for your doctor next time. Or, maybe it just inspires you to explore one small area if you touched on a bit further, something that might enhance your own well-being based on what you've learned today.